We'd like to welcome Dr. Maya Grisaru as our guest speaker for today. For those of you who haven't read the posts, Dr. Grisaru is a specialized radiologist with 3 years of subspecialty training, including both clinical and research fellowships in breast and abdominal imaging. She also holds an MBA with a specialized focus on healthcare, innovation, and entrepreneurship. Dr. Grisaru is currently an assistant professor in the Department of Diagnostic Imaging at Western University in Ontario. So over to you, Maya.
Thank you so much for the introduction, and thank you everyone for joining and having me today. It's an honor. So I have a lot to cover. I've been asked to give a talk about breast MRI, the role of it, and the BI-RADS. So I will do my best to cover everything in our hour and a half. And the objective of this talk is to cover some of the basics, the sensitivities and specificities of the technique. Then I'll talk about the roles of breast imaging with MRI, the enhancement kinetics, which is the added value, unlike a mammography or ultrasound, indications of MRI in breast imaging, which are very specific. We'll talk about the approach to breast MRI, how to do the interpretation, how to build the structure of the report itself, a description of the findings, and everything will be based on the BI-RADS category. So all the wording and lexicon that I will be using to describe different lesions will be based on the breast BI-RADS lexicon, and we will discuss and cover the BI-RADS categories as well. At the end, I will show some cases of common benign and malignant findings with MRI. And finally, if we'll have time, I will mention a bit about breast implants with MRI imaging and MRI biopsies. Depending on the time, we'll see. I do want to leave some time for questions and answers that I've prepared at the end that will hopefully help summarize everything and just help you remember some of the key points that I want you to take away from this talk. I'm hoping to leave some open, few minutes for open questions if you might have any. So let's dive in. So in terms of sensitivity and specificity of MRI, breast MRI has the added value of breast MRI is the ability of it to be kind of giving us the ability to scroll through the images. So it's more of a 3D imaging, unlike the traditional mammography that we have for breast imaging. It's considered to be the most sensitive modality in terms of breast imaging. The sensitivity, well, the reports are a big difference between the different articles in the literature, but it's pretty high. It's ranged between 85 to 100% in sensitivity. So it is very a strongly sensitive study. It even has a better performance in sensitivity for high-risk population. I will mention later on in the talk what does that high-risk population include, who are those women that will include in that group of patients. In terms of specificity, unfortunately, is not as high as the sensitivity, but it is quite high, ranging between 70 to 90%. Now, it is important to remember that MRI is not coming to replace any of the other traditional breast imaging modalities like mammography, 2D mammography, tomosynthesis, ultrasound, and so on, or contrast mammography, which is a new and more increasingly used nowadays. But it's more of a complementary study for a specific group of patients that will need that extra imaging modalities. And this will come up later on again and again throughout the talk. So there are different techniques to perform the breast MRI with different types of sequences that can be included. And I will mention some of them. In general, it is best practice to use a 1.5 Tesla MRI machine. We do need to use a dedicated breast imaging coil, which is the one I'm going back. No, next picture. I will show you a picture shortly. Oh, no, it's this. This is the breast coil, where the patient is lying supine with head facing down, and the breasts are hanging loosely from those two holes within the coil. So this is the dedicated breast coil. Sorry, I'm going back to where I was. So as I mentioned, the patient is lying supine, like you can see in here, in this picture, with the breast hanging down through the cords. It is recommended that the thickness of the slices will not exceed 2.5 millimeters, so we can have a proper morphological evaluation of the different breast lesions and findings that we might see. The imaging are typically acquired in the axial plane. In certain places and institute, they might include the sagittal view as well. In our practice in Canada, we usually include both of them. It just helps us get a better understanding of where we are within the breast and kind of the three-dimensional size and extent of a certain lesion. So we like it, but not every place acquires those. Again, every image and sequence you choose to add will prolong the study. So that's a consideration. The field of view of the MRI should include both breasts entirely, including the nipple. Nothing should be cut out. The area of the axillary region needs to be included as well. And to maintain spatial resolution and the overall proper resolution of the image itself, we can give away the posterior aspect of the chest wall, which is not part of the clinical question when we are inquiring about breast finding. So usually most of the sequences will look something like that, kind of including the heart and the anterior chest wall, portion of the liver. But the main thing that we need to look at is the intramammary chains, if there are any lymph nodes along those vessels, the axillary region in the different levels, level 1, 2, and 3, and the breasts. So in addition to the 3D kind of ability of seeing findings with MRI, another benefit is the contrast injection. And the basic principle behind the contrast injection is the neoangiogenesis that leads to formation of leaky vessels, or of those blood vessels that develop within a tumor or within a lesion that are abnormal compared to the normal vessels in a normal tissue. And they result in holes within the vessels that allow the contrast media to escape and sink into the surrounding tissue. So we base, of course, the contrast that we inject is gadolinium, like with any other MRI study. There is the microcyclic and macrocyclic. I will not go into too much details on that, but there are different pros and cons. The dose of injection is usually 0.1 millimole per kilogram, with a rate flow of 2 milliliters per second. Now, there is no evidence in the literature that a higher dose results in better outcome or better performance, and that's why this is the typical recommended dose. Now, studies did show that the peak of enhancement of most cancers are around the 1 minute to 90 seconds after injection, which is why this is the time frame where we usually take the first post-contrast image, so around the 1 to 1.5 minutes after injection is being given. So as I mentioned, there are several types of breast MRI studies. The classic ones include like the must-have in every breast study, when the purpose of the study is to assess parenchyma and not implants, as I'll mention shortly, are the T2, so the bright fluid sequences, to visualize the mostly benign lesions, better characterized cysts, lymph nodes, seromas, maybe post-surgical changes, and so on. And a multi-phase T1 fat-saturated sequences. So multi-phase meaning that we need at least, we need one pre-contrast, so we can better differentiate it and determine if something is really enhancing or maybe just containing proteinaceous material, as we know, will also show high signal on T1. So to be able to differentiate between those lesions, we need to see the before and after injection. So that's one. And then usually we acquire at least 3 post-contrast T1 sequences with fat suppression to see how a lesion behaves in different timeline after the injection. And I will show some graphs to describe the different type of behaviors and enhancement kinetics, which is how it's called. And of course, the subtraction images are also usually part of the breast the study protocol, which are post-processing images based on the T1 post-contrast, where we just have the enhancing things within the breast being shown up and light up as a high signal, while everything else is kind of subsides. So we won't confuse proteinaceous material or non-enhancing tissue and so on. And I will show images of everything. Of course, specific sequences can be added based on the specific scenarios. For example, for breast implants, there is no need to inject any contrast media if the question is regarding an implant rupture, right? Intra or extracapsular, so there is no need to inject. We will need specific silicone sensitive sequences for that. Additional sequences that can be considered to offer is a non-fat saturated T1 weighted sequence. So it's not a must-have like the T1 and the multiphasic the multiphase T1 and the T2. The non-fat saturated could be helpful to help characterize and identify macroscopic fat within specific lesions, such as lymph nodes, hamartomas, lipomas, for example. Usually, lesions that contain macroscopic fat within the breast are more suggestive of benign lesions. So in our practice, we do incorporate those sequences, the non-fat T1 sequences, but again, it can change and it's not a must-have. Another option is the diffusion-weighted images, the SWI and ADC maps. That can also be added in specific scenarios, depends on the history, institution protocol again, and the clinical question. In our practice, for example, we do not inquire them simply because the time added for each study that you will need, it will make the study longer, and of course the interpretation longer because you will need to take extra time to look at those images. So we do not include them routinely, but we do do them in case of when injection is not an option. If the patient is allergic and still needs a breast MRI, we might get additional value from those diffusion images to see if a lesion demonstrates any restriction or these type of concerning features other than enhancement in case we cannot inject. Another a big use in those sequences is pregnant women. In the past, we used to inject contrast during pregnancy, but in the last decade, it's known that it does not leave the body properly, so it is not recommended to inject the gadolinium during pregnancy. So that's another scenario where you might consider adding those diffusion-weighted images instead. Post-processing sequences include the MIP, which we do use routinely. A MIP is a big factor. It's a kind of a 3D image that you can play with. You do not scroll through it, but you can rotate the image. And I think I find it very helpful to start with that in every read. I will show examples later on. We also have the color maps in some practices. Not all practices have them. It helps us outline the enhancement kinetics and understand the behavior of the tumor with the post-injection and the vascularity that is within it. So far it was the classic plus minus additional sequences that you may consider in specific scenarios. Now, this is a different type of MRI study protocol. It's a more recent upcoming a protocol that is in the more recent literature that is being offered, and it's the ultra-fast breast MRI. The notion behind ultra-fast MRI is that cancers, most cancers enhance in the first 10 seconds after contrast injection. And benign lesions usually take longer to enhance. So the enhancement pattern is different between the two. And to catch those cancers that enhance early, the idea is to obtain the first sequence after injection, not at 60 or 90 seconds after injection, but immediately within the first 10 seconds of injection. The problem with that is that you need a machine that is newer and faster to be able to acquire that image in a shorter and faster time frame. Otherwise, by the time you end obtaining the sequence, the time is already passed and you're past the 10 seconds mark, and the information that you get is not as relevant. So in our practice, our machines are not that new, and we do not have that option. So I don't have much experience with that. But in some, I think very few practices use this nowadays, but it is something that is upcoming. Another option that is also in more recent literature is the abbreviated MRI. It's based on the notion, on the known fact that MRI has a high cost and limited availability all over in most countries, if not all. So the idea here is basically to do less sequences to reduce the time per patient that needs to get the study, and reduce the interpretation time by having less images and sequences to look at. So the idea here is to obtain one T1 sequence before injection and one T1 post-contrast sequence, and taking a look at only those two sequences. So basically, you exclude all the T2, the non-fat suppressed T1, the post-processing, subtraction, and all of that, just to save time and make the study much shorter, so you can accommodate more patients in a shorter time interval. And the studies that demonstrated this type of protocol show that there isn't a significant difference between that and the full MRI protocol. So it is a newer method. I can say that we are considering and trying out and see how we do with that type of protocol. I might be against doing that for the first time, baseline MRI in a patient, but maybe as a follow-up after you have the full understanding of the breast and what's there and what's not and how things behave, maybe as a follow-up, this is a good option to try and make MRI available for more patients. So as I mentioned before, in addition to our ability to scroll through findings and the breast, we have a big part of the MRI is the enhancement kinetics, is how lesions behave after the contrast injection. And that tells us a lot about a lesion. So this refers again to the breast lesion enhancement curves, and it's also known as the cold enhancement curve. And the enhancement intensity and the quality curve is an important features to determine the aggressiveness of a lesion. There are three types of curves: the washout, plateau, and persistent, which is type 3, 2, and 1 in this case. And this is the order of their level of concern. So from the highest concern, which is the washout, to the least concerning enhancement kinetics, which is the persistent. And this is done, the way we determine is basically taking the ROI and measuring the HU units in each lesion in the same spot on the different timeline after injection, and see if it changes, if it increases or decreases, and what exactly are the changes. So this is how it might look confusing, but I hope I'll make it seem more simple. But these are basically the three types of curves that we have. So the first one, the type 1, is the progressive pattern. So this is the least concerning and most suggestive of benign lesion. And if this is the time curve, all of the on the x-axis. And this is the point of time where we inject the contrast. Here we do not take any images at this time frame. And at the 60 to 90 second mark, we start scanning and taking the post-contrast images. So we'll take one after 1 minute, the other one at 2 minutes, 3 minutes, and so on, depending how many sequences we want to obtain. And what this type shows is that first there will be a slow uptake of contrast by the lesion. And when we start scanning and taking the images, we will continue to see that short, slow uptake of contrast. So if I'll take a lesion, I'll show an example shortly, and I'll measure the HU, it will show persistent, slow enhancement in the density in that area within a lesion. So this is continued decrease in signal intensity over time, usually benign lesions. Most of them, 83% of them will be benign, but remember that some malignancies can also demonstrate benign type of enhancement curve, and 9% of them could be malignant. So don't count only on the enhancement curve, but we need to consider all factors, including the morphology of a lesion, if it's newly developed, if it's stable. So we need to consider everything and not just one parameter by itself. The sensitivity of this is a bit more than 50%, and the specificity is 71%. Now, the second type of the enhancement curve, the plateau pattern, demonstrate a slightly more rapid uptake of contrast. And at the time point where we start the scanning, we will see no change in the density of a lesion. So there will be a plateau, and therefore the name type 2 plateau pattern. And this is kind of an intermediate suspicious. So it's not typically benign. It's not very concerning for malignancy, but it's more concerning than not. So the initial uptake followed by level of signal intensity. This suggestive of malignancy. The sensitivity here is around 42% and specificity 75%. The type 3, the washout enhancement curve, is the most concerning curve, where we see a rapid uptake of enhancement within the lesion and then rapid washout within the lesion. So if we'll measure the HU within the same lesion in the same spot at a different time point after injection, we will see that it actually decreases and not increasing. So this is a washout. This is the new vessels bringing up fresh blood and washing out all the contrast. And this is more concerning for aggressive lesions, for malignancies. Having said that, I will mention that lymph nodes also every lymph node has its own vascular arterial supply, so they will show a washout as well. So just be minded of that and look for that kidney shape and fatty hilum, so you won't start biopsying every lymph node thinking it's malignancy. Another point to remember, that lesions that do not enhance doesn't necessarily mean that they're benign. So low-grade malignancies or DCIS might not enhance. So it's just a thing to remember. And again, we need to look at everything as a whole, the morphology, the enhancement kinetics, the clinical scenario, and everything together. So this is an example of a patient with a clear mass within the left breast upper outer quadrant. You can see that the mass is irregular, some ungulated margins. Again, all the words that I'm using to describe are part of the BI-RADS lexicon. The enhancement is heterogeneous mass enhancement and not homogeneous. And you can see that the background parenchymal enhancement, the normal tissue of the breast, also has its own blood supply, which is normal. And with time, it will show increasing uptake of that contrast, which is what you see in the difference here. This image, this is basically post-contrast subtracted images. So this is the image that was taken at time 1 minute after injection. If the injection happened here, we waited for 1 minute. So the first image was taken here, which is what we see here. And then the middle image is the image that was taken after 3 minutes from injection. So we see the accumulation of contrast in the background parenchymal enhancement in the normal tissue. And we see that the lesion, although everything looks a bit more brighter, but I know it's harder here because it's not a dedicated screen and this is a PowerPoint through Zoom, but if you'll put a ROI and measure the density here, you will see that this density measures actually less than this density, meaning that there is a washout. There is a rapid washout of all the contrast media. So this is definitely concerning for malignancy, in addition to the morphology and everything else. This is a typical image of CAD, of that maps that uses colors to show us the different type of enhancement curves. Usually the red, as you can see in the heart, represents the washout, the rapid, the more concerning lesions. But of course, in the heart and lymph nodes, we do expect rapid washout as the blood flows there much faster. While in the tissue, in normal breast tissue, we see more blue, which is representative of the, sorry, less the type 1 enhancement kinetics, and green usually represents the type 2 enhancement kinetics. So there are specific roles for breast MRI, screening of high-risk patients, staging, management of patient undergoing neoadjuvant treatment, evaluation of specific clinical or imaging findings, and MRI biopsies. And I will elaborate about each of them. So for screening, this is a big place where MRI plays a role in breast imaging. So we don't use MRI for screening of any patient. We use them for high-risk patient. What does that mean, high-risk patient? It's patients that have higher risk than the average female to get breast cancer through her lifetime. So the cutoff is above 20% risk. And the people who will be included in that group of high-risk patients are patients with positive genetics that are known to be associated with breast cancer, like BRCA1 or 2 or others, patients with, sorry, strong family history of breast cancer or first-degree relative with BRCA and genes or syndromes that are associated with breast cancer. Patients with prolonged estrogen exposure are also at increased risk. And patients who were treated with radiation treatment to the chest wall during their childhood have also increased risk of, sorry, of breast malignancies. In case of average risk women, like most of the population, MRI is offered only for specific problem solving. If there is a specific surgery that complicates and the mammography is not good enough, or some patients do a free silicone injection or free fat injection for cosmetic reasons, which can complicate and really make our life difficult in terms of diagnosis with ultrasound and mammography. So that's where we can offer that if available. But again, it's important to remember that screening with MRI does not mean that the patient doesn't need mammography. It's in addition and not as a replacement. Calcifications, for example, which DCIS mostly present with calcifications, you will only be able to see on mammography and not on MRI. MRI will not show calcifications. Another indication is staging. So patients with dense breast with known malignancy that we might think or be concerned that we might be missing some of the lesions, that they could be obscured by the breast, by the dense breast density on mammography. So MRI can be offered to assess for chest wall, nipple invasion, satellite lesions, and other factors to help better understand the disease extent and plan for surgery. Just a quick reminder for lymph nodes, everything lateral to the pectoralis muscle is level 1, everything behind is level 2, everything medial is level 3. Just it's important to look at all three of them because that's different staging for the patient. And it's important for the oncologist, and this will determine whether this goes for neoadjuvant or surgery or what will be the course of action for that patient. For neoadjuvant patients, so patients with extensive disease that might need neoadjuvant with dense breast, we can offer MRI as a baseline before they start neoadjuvant to know what's the starting point, what's the extent of disease, like we just discussed with the staging. Then we offer the second MRI after 2-3 cycles of chemotherapy to see whether this is going in a good direction, where there is response to treatment. And at the end, after completion of neoadjuvant treatment, we can offer MRI again to see the residual disease, if there is complete response, if everything has cured and responded to treatment, and to help the surgeon plan the surgery based on those changes. Additional evaluation, as I mentioned before, in case of free fatty or free silicone injection, or if there is any clinical indication that we could not solve with mammography or ultrasound, like bloody nipple discharge with no reason that is persisting, abnormal cytology, anything that we could not answer and solve the problem with the traditional modalities, we can consider adding MRI. And of course, implant assessment for ruptures and so on. Approach for breast MRI. So how do we report? So I'll show you shortly my personal hanging protocol that I use. But we start with review the clinical history. So why the patient is there? Is it for screening? Is it for known cancer? Is it for neoadjuvant? Is it specific clinical questions? And we need to make sure we answer those questions, like with anything, with any other modality in any other part of the body. And then we start with evaluation of technique. Like with mammography and ultrasound, we need to see whether we are happy with the study, if the study is satisfactory, if we can rely on the images, if we think there are too many artifacts, maybe this is non-diagnostic, too much background parenchymal enhancement, and so on. Following that, I usually start with the MIP, with just kind of to see an overview of what am I expecting. Is there a lot of background, a lot of tissue, a lot of findings, fibrocystic changes, and I usually put them side by side with a prior MIP if I have comparison, and to see if any big changes. And then I start digging into each lesion that I see and to characterize them on the T1 and T2 and see how they behave in the different sequences. And of course, always compare to prior, if you have prior, and if not, look at the mammography, see if you find a correlate on the other modalities. And eventually we need to give a review of all the structures outside of the breast. Like with anything else, we do need to make sure we didn't miss, I don't know, metastatic in the ribs, for example, if it's for staging, or incidental liver lesion or chest lesion or anything like that. So of course we need to look at the surrounding. So this is my hanging protocol. The first image here is the MIP. This is how it looks like. As you can see, nothing much is enhancing other than the blood vessels and some small normal appearing lymph nodes in the axilla. This is the T2 with fat set. So everything, the fat is dark. This is a very fatty replaced breast. So this is density A category. And you see that there is no contrast. Of course, the T2 is taken before the contrast injection. So the heart and liver and all the organs in the chest wall and mediastinum are dark. This is the T1 non-fat set that we usually obtain. Not, again, this is not a must-have, but it helps to see if there is any macroscopic fat within a lymph node or any lesion that might contain fat. This is the post-contrast T1, and we can see that by seeing the contrast within the heart, in the liver, in the blood vessels, in the intramammary chain, and within the breast if we'll see lesions. This is the subtraction images. So again, only things that enhance will be bright on this image, like the heart, like the blood vessels, the tip of the liver, some in the nipple. The nipple are a bit vascular, so it's normal to see some enhancement there. And as I mentioned, in our practice, we like to take the sagittal, obtain the sagittal sequence as well, just to get a better understanding of disease extent and lesions and where we are within the breast, but it's not a must-have. So report structure, this is based on the BI-RADS lexicon and categories. We start with indications for exam, MRI technique, description of the overall breast composition and background parenchymal enhancement. This is a must-have. We have to mention that. A clear description of the main findings with comparison of prior, and eventually we need to summarize the report with assessment and management. Assessment meaning summarizing the findings with the assessment category, and management for further, what else do we want to have done with this patient. So this is just a bit more information on each. So within the report structure, we start with the indication for the examination. So we need to provide a brief description of the reasoning for the study. It should contain a concise description of the patient's clinical history. So for example, I have two examples from different scenarios. 32-year-old high-risk patient presented for routine screening, or a 40-year-old patient with dense breast and recent biopsy-proven invasive malignancy presented for further assessment of disease extent and surgical planning. So we need to make sure we understand what the question for the exam is, so we know what to answer. In terms of MRI technique, it's important to mention basically what we included in the study, which protocols, which sequences did we use. This is just our typical protocol that we use. And as you can see, dynamic or Gadovist injection, following administration of Gadovist injection, the dynamic axial and sagittal sequences were obtained at 1, 2, 3, and 5 minutes. This is our typical protocol, in addition to the non-contrast T1, T2, and everything else. So MRI findings. So before we go into each finding based on the BI-RADS lexicon, we need to mention two things. Always mention, just like with mammography, we need to mention the breast density. So we have 4 categories, A, B, C, and D. A, when the breast is almost entirely fatty. B, when there is scattered fibroglandular tissue and it's up to 50% fibroglandular tissue and 50% fatty tissue. C is the heterogeneous fibroglandular tissue when it's up to 75% of the breast covered with fibroglandular tissue. And D, when the breast is extremely dense, most of it covered with fibroglandular tissue, which of course makes our life harder with mammography and mammography less specific. And that's where we might consider adding the MRI in certain patients. The second thing that we need to mention before going into each lesion is the background parenchymal enhancement. So again, normal tissue has normal vascularity, and we will see enhancement. It depends on the menstrual cycle. It depends on the age of the patient. It depends on hormone take, if she's taking hormones or IUD, for example. Sometimes it's not easy to determine where she is in the menstrual cycle. We used to schedule the MRI appointment at the second week of the patient's menstrual cycle to try and minimize the background parenchymal enhancement, but more and more studies are coming and showing that this is not as helpful, and it makes the booking office and the availability of the studies much more complicated. So we are no longer scheduling it accordingly, and we're just doing our best per the specific patient. And hopefully when we have prior, at least we know where to compare and what do we expect, and if in case something is new. But again, like with density, we have 4 categories: the minimal, mild, moderate, and marked. And as you can see, it just depends on how much background parenchymal enhancement you see. So that's an important factor to mention. And of course, if it's marked, you can also mention if it's really marked and you can barely see anything, you can also say that the study is non-diagnostic and bring the patient back in 6 weeks. And in 6 weeks, she will be in a different timeline in her menstrual cycle. Whatever the timeline is currently, she will be in a different one. So you can try or give it another shot then, instead of letting her wait another year. And now description of findings. So the specific findings, we need to mention for every lesion that we do describe. We don't need to describe everything, but if you do choose to describe something, you need to cover the size, the location, the enhancement pattern, the morphology, and if there is any relevant associate findings. So for size, either you give 3 dimensions, or I personally give the maximal dimension of each lesion, the location, right or left breast, the quadrant, which quadrant are you in? If you're able to say the o'clock phase, 3 o'clock, 9 o'clock, depending where you are relative to the nipple. If not, give a quadrant. And we also mentioned the third, which are we in the anterior third of the breast, middle third, or posterior third, and we'll show some images later. And then associated features, if there is artifacts, if we see, what kind of findings do we see? Do we see a focus, a mass, or non-mass enhancement? Now, focus is kind of an old descriptor that was used in the old BI-RADS lexicon. I still, well, I don't really use it anymore, but I want you to be aware of, which is why I left it here. But it's basically a small mass. Now it's called a small mass. It used to be called a focus. But what it means, it's a tiny dot that it enhances kind of differently from the background parenchymal enhancement. It's more obvious or prominent or pops out and you kind of notice it, but it doesn't have a mass effect. It doesn't shift things around. It doesn't cause distortion. It's too small to measure the enhancement within it. So it's not a mass, but it's a tiny one. So now it's called a small mass. It used to be called a focus. Masses, they used to be considered above 5 millimeters. Now everything is a mass, unless it's a non-mass, of course. But it's a more space-occupying lesion. It's usually spherical, oval, irregular. It depends. I'll mention the BI-RADS descriptors in a few minutes. But it has some effect on the surrounding tissue. And of course, you can measure and see the enhancement and how the enhancement patterns and how it behaves. Non-mass enhancement is kind of a more amorphous enhancement, and it's not a mass, a three-dimensional finding. It's more blends in within the tissue, but it should be separate from the background parenchymal enhancement. So something that is more obvious, that is more enhancing, that's called a non-mass enhancement. So for masses, we need to mention the shape, if it's oval, if it's round, if it's irregular. We need to mention the margins, circumscribed, if the margins are well circumscribed, if you kind of pencil them out and draw them, or if it's non-circumscribed, if it's irregular, microlobulated, spiculated, all of those features, or angulated margins, which are more concerning for malignancies. And of course, the internal enhancement kinetics, whether this is homogeneously enhancing, heterogeneously enhancing, like with a lesion that is more aggressive and will have necrotic changes within it, then the necrotic part will not enhance, so the enhancement will be more heterogeneous. Rim enhancement, whether the rim is nice, thin, like for cysts, for example, an inflammatory cyst, or if there is thick, irregular rim parenchymal enhancement, which is more concerning for a malignant lesion. And of course, dark internal septations or non-enhancing septations, it's a typical characteristics for fibroadenomas, and I will show example. So this is a non-mass enhancement. As I said, it's not a space-occupying lesion in terms of mass effect. It does not have a significant mass effect on the surrounding. It's more amorphous, but there is definitely enhancement that is more prominent than the surrounding background parenchymal enhancement. And we describe it by its more or less shape and distribution, focal, linear, segmental, regional, if it covers a quadrant, multiple regions, or if it's diffuse and involves the entire breast. And of course, everything, try and see if this is symmetric. I mean, like anything in the body, it's very helpful that we have both we're kind of more or less symmetric, and that's helpful to see if something pops out and looks different than the other side. And also here we can say, talk about the internal enhancement pattern, whether this is homogeneous, heterogeneous, or clumped nodular. Clumped nodular is kind of like a patchy non-mass enhancement, again, with no definitive masses within it. And if we do see something concerning, we need to mention associated features like nipple retraction, nipple inversion, skin retraction, skin thickening, skin invasion, if it's direct invasion by the mass or it's direct invasion, a kind of a secondary finding due to inflammatory changes, like in inflammatory malignancies, axillary adenopathy, lymphadenopathy, and then which level are the lymphadenopathy? This changes the management. Protocol, the pectoralis muscle involvement, or even deeper chest wall involvement, and of course, surrounding architectural distortion. Additional findings that are not related to the main finding, or if at all, maybe you don't have necessarily cancer in every study, so we do need to see if we see intramammary lymph nodes, Usually they are benign. We see them commonly. We don't even need to mention if there is nothing concerning about them. Of course, that if they're big and prominent, then yes, we do need to mention, or changing, we will, but otherwise, no need to mention. Skin lesions are usually of non any clinical significance. Ductectasia with internal debris, usually not of any clinical significant, unless the patient is coming in for nipple discharge. So we can mention that. But if you don't see a mass or anything that will cause that, then there is no concern. Cysts, we need to identify cysts, fibrocystic changes. Again, all of these findings, if we do find them, will be a BI-RADS 2. Nothing to do about them. It's not concerning. No need to proceed, but something we need to mention and just make note that we saw them, we are aware. So for next time when the patient comes back, we can follow that, see that those findings are stable. In case this is a patient with post-surgical or post-therapy changes, so skin changes, distortion, if there are any non-enhancing lesions, architectural distortion, whether from prior cancer or something new, or surgical changes, maybe biopsy changes from an old biopsy that was done 20 years ago, single voids from foreign bodies like surgical clips or post-biopsy clips, and all of those we could choose to mention. You don't have to, but you could. And as I mentioned before, fat-containing lesions. Of course, we always need to compare to previous. Prior studies make our life easier and help us avoid unnecessary workouts. Even if we see something, I don't know, that it looks a bit concerning, and I will show example in those cases that I have for you. We might not go and chase it because we've seen it before and we know that it's there and it's stable. Otherwise, we might consider a biopsy. So comparing to previous MRs or alternative other modalities, because again, MRI needs to be a complementary study and not replacing anything. So there should be a mammography or even a chest CT from 5 years ago, if you're concerned about something, whether it's new or maybe it was there all along. So always try and find answers in other modalities. Eventually, we finalize the report with the assessment category, so kind of a summary of the findings and our level of concern and what do we want to do about it. So the management's recommendations for management. So, and the BI-RADS category, of course. Sometimes these are a bit separately, but you can also kind of combine it together in one section in the report. If you think you need more additional imaging, like ultrasound or anything else, you can consider giving a BI-RADS 0. Usually, we try to avoid giving BI-RADS 0 for MRI findings, simply because the notion is that MRI is the most sensitive study. So if we cannot solve the problem with MRI, what else can you offer to get a better answer? So try to avoid giving a BI-RADS 0. And if you do see something that, for example, you think it's a fibroadenoma or a lymph node and you want to confirm with ultrasound, which is reasonable, you can either give it, say, likely fibroadenoma or lymph nodes, second look ultrasound. If no sonographic correlate is found, then follow up with MRI if you're not concerned, or if no sonographic correlate, then MRI guided biopsy if you are concerned. So depending, but kind of, and then giving it a BI-RADS 3 or BI-RADS 4 instead of a BI-RADS 0. So just consider that. But again, it's not a rule of thumb. If necessary, you are allowed, based on BI-RADS criteria, to give a BI-RADS 0. Okay, BI-RADS categories. How am I doing with time? Okay. So BI-RADS categories, there are 6 categories. They are very similar to the BI-RADS category with the mammography and ultrasound, which I'm sure you are familiar with. So BI-RADS 0, again, it's when you need additional imaging, when you need something extra to get to the final conclusion and decide how you want to proceed with things. Category 1 is when there is 0 chance of malignancy. Category B, again, 0 chances of malignancy. I will go through each one of them and discuss further. BI-RADS 3, there are specific rules about BI-RADS 3, but generally, this means that the finding has less than 2% chances of being malignant. So between 0% to 2% chances of being malignant. Category 4, there is the subcategories of 4A, 4B, 4C, but in general, we can call it a category 4. where the chances of malignancy is between 2 and 95%. So it can range. This is a big range. And this basically includes all the lesions that are not like typically malignant, 100 for sure malignancy, but they are not also typically benign, and you do need to do a biopsy for them to either prove out benign finding or prove malignancy or exclude malignancy. BI-RADS 5, those are the typical textbook malignant findings that are more than 90%, 95% chances of being malignant. And if you receive anything else with pathology, it will be discordant because of your level of concern is so high. Category 6 is only after biopsy was already done and the lesion was proven to be malignant. So BI-RADS 0, again, try to avoid that with MRI and figure out what will be the next step, even if you do need more images. So like I mentioned before, if you need the ultrasound for, if you see something that is not concerning, recommend second look ultrasound, and then if no correlate, or if there is a correlate, then follow up with either ultrasound or MRI. Or a biopsy, if you find the finding is not typically benign, but kind of in between, and you still want a biopsy, but maybe we can do the biopsy with ultrasound. So just try to avoid that, but still it's an option if you think that's helpful. BI-RADS 1 and 2, I put them together. Both of them mean that the study is normal. The difference is that in category 1, you chose not to describe everything, not intramammary lymph node, no cysts, or anything that is typically benign, and the patient will come back for the next follow-up, the next routine screening, no need for a short-term follow-up or anything like that. And the category B is when you did choose to describe something that is benign, like post-surgical changes, intramammary lymph node, a known fibroadenoma that has been stable for years, or anything like that, or clips, or post-surgical clips, or anything like that, or implants even. If you describe anything within the breast that is benign, you give it a BI-RADS 2. If you don't describe anything and the study is completely normal, you give it a BI-RADS 1. Either way, in both cases, there is 0 chance of malignancy, and the patient will come back for next screen in 1 year. BI-RADS 3 category, probably benign. So again, it means that the chances of malignancies is between 0 to 2%. And probably benign lesion does not expect to change much within a certain time frame. So we will recommend BI-RADS 3, meaning that we recommend short-term follow-up. So instead of waiting a year until the next follow-up, the patient will come in 6 months. The next follow-up will be in 6 months. And the next follow-up will be in a year from that. So 6, and like 6, 12, and 24 months. Which overall we need to establish 2 years of stability to call something benign, and then we can let it go and downgrade it to a BI-RADS 2, and no need to continue the short-term follow-up. But again, BI-RADS 3 category should be given to specific findings and not findings that may need a biopsy, and not findings that are apart from background parenchymal enhancement. So it takes time to kind of adjust our eye and get used to separating lesions between background parenchymal enhancement. So probably findings, if the finding that we are following after is now after 6 months that the patient is showing up, now it's resolved or smaller or less prominent or not as enhancing, less concerning, we can downgrade it already to BI-RADS 2. No need to wait 2 years. If the lesion is changing otherwise in a more concerning way, increasing in size, more irregular, more enhancing, it behaves differently, then yes, we do need to go to biopsy. This is exactly why we're following those lesions. In a scenario where the stability of a finding is unknown, for example, a baseline mammography with a patient with first-time mass, it looks like a fibroadenoma. You can offer second look ultrasound to confirm, but even if you didn't see anything on ultrasound, then you can do a BI-RADS 3 and follow up that lesion, okay? If it's something new, you have a prior, it wasn't there, it's new now, completely looks benign, matches all the criteria of benign lesion, but it is new and you can confirm that it's newly developed, then it's a biopsy. Because remember that all those patients who are receiving the breast MRI are high risk to begin with. So they have higher chances of receiving breast cancer in their time life than the average population. So we need to be extra careful with those patients. And those patients are typically younger and have more aggressive cancers. So if we'll wait 6 months, that can be a critical a change for the patient. So BI-RADS 4 category, again, this is saved for those lesions that are not typically all the way malignant for sure, but do require biopsy. It's between 2 to 95% chances of malignancies. In general, we do recommend lesions above 5 millimeters to try and do a second look ultrasound, see if we can find it under ultrasound, simply because ultrasound guided biopsy, it's much easier, simpler, more available, cheaper, and just easier for the patient also. It's not as uncomfortable to lie down on the MRI machine for 40 minutes. So if we are able to identify it on ultrasound, great, we can biopsy it under ultrasound. If we're not sure if this is a good correlate, then we proceed with the MRI biopsy. Or if we didn't find it on ultrasound, then we'll proceed with the MRI biopsy. BI-RADS 5 category is highly suspicious for malignancy. This is basically saved for the anything that is more than 95% chance malignancy, meaning that if I'll do a biopsy and I'll get a benign result, I will probably call it discordant, and I will still either repeat biopsy or send to the surgeon to have it removed because I don't rely. Maybe a dumb needle was a bit off, maybe the biopsy site wasn't accurate, something migrated, so I will consider that discordant in those cases. Unlike the BI-RADS 4, which could be malignant, could be benign, I'm kind of still debating, and it's non-specific on either way. Category 6, as I mentioned before, this is reserved for examination preferred after biopsy was already proven to be malignant. And the category 6 should be given after we're done with assessment. Meaning that if the patient has cancer on one side, but there is still a ongoing assessment of something else within the same breast or the other breast, we still give the BI-RADS category based on the other lesion. We give the BI-RADS 6 after we are done, and the patient can move on to the surgeon or oncologist and further management. So I have some examples of cases. So I'll show some typically benign common findings that we see on MRI, and then some malignants. So this is a 42-year-old patient with high risk chances for malignancy. She's more than 20%. She presented for routine screening with MRI. So here, this is the MIP. As I mentioned, I like to start with the MIP images. This is the T2 fat suppressed images. We can see that there is non-mass enhancement within the left breast outer aspect. We can see that it's very homogeneously bright, strong bright on the T2, which is a supporting feature for benign lesion. And then on the post-contrast, we see that this finding is enhancing. This is the T1 fat set post-contrast, and this is the subtracted images. So you can see the difference between them, how everything is kind of blackened out except what is enhancing. So if I would see this in a first-time study, I will definitely biopsy it because this is asymmetric. This is non-mass enhancement in a patient that is already high risk, even though it has benign imaging characteristics. Maybe I'll try to do ultrasound and see if I can see anything, but even if I don't, I would biopsy. But in this patient, before I show you the previous, here I have the pre-contrast. You can see that this is not enhancing and that this is becoming brighter on the post-contrast. And this is the different timeline. This is 1 minute after injection, 2 minutes after injection, and 3 minutes after injection. And you can see that this is becoming more and more enhancing and more brighter. So again, type 1 enhancement kinetics, which further supports benign findings. So it's bright on T2, type 1 enhancement kinetics, so far looks benign characteristics. And when we compare to prior, so this is the current one, the MIP that we saw with the enhancement. This is 2 studies from 2022 and 2023 show no enhancement. So if I only compare to this one, I would say, oh my God, this is definitely developing. It's a new finding, even though it has benign imaging characteristics, definitely needs a biopsy. But if I look even further to a remote study from 2019, you can see that this was there all along. So this is basically fluctuating. I mean, if it was a cancer, really was a cancer, it will not just disappear and then come back, right? So this is basically fluctuating background parenchymal enhancement. And after seeing that this was stable, looks similar to 2019, which is way more than 2 years, I can let it go and give it a BI-RADS 2. Another case of a 32, high risk, screening and known fibrocystic changes. So again, I start with the MIP. As you can see, this is marked background parenchymal enhancement. Look how hard this makes our life. You see so many enhancement. It's so hard to understand who is who and what is what, which is why it decreases the specificity of our study. This is the sagittal T1 post-contrast and the axial T1 post-contrast. And as you can see, we see those masses that are non-enhancing, low signal on T1, high signal on T2. This is the subtraction images, definitely not enhancing. So these are simple cysts. This is what fibrocystic look like. And commonly, you will see marked background parenchymal enhancement with those patients with fibrocystic changes because of all the hormonal, and the breasts are very active and very fibrocystic. So it usually comes with that increased background parenchymal enhancement. And this is the same patient with the prior MIP. So as I mentioned at the beginning, I like to compare MIP to MIP, one to other. And you can see that overall, this is an improvement compared to what she had last year. Last year, it was marked background parenchymal enhancement. You could barely see anything. So this is, as much as it looks bad, it's still an improvement. So always compare to prior. This is a different patient with a mass seen in the left breast along the 3 o'clock radian, right? Because we're at the level of the nipple and this is outer, so we are 3 o'clock. And this is again the timeline. You can see that the increase in background parenchymal enhancement, this is 1 minute after injection, 2 minutes after injection, and 3 minutes after injection. And you can see that the mass is relatively increasing in enhancement. It's brighter and brighter as we with the timeline as we go further from the injection site. This is the sagittal view. This is just a zoom in on the same view. And you can see that this is an oval-shaped mass, very well circumscribed, unlike the cancer you saw before. And there are some linear, thin, non-enhancing septations within it, which is a very typical feature for fibroadenomas. Now, in smaller fibroadenomas, it will be harder to see, but still very typical feature. This is the sonographic correlate. We can see a clear, oval-shaped, well-circumscribed, hypoechoic mass with those septations. And those septations that we see on ultrasound as echogenic correspond to those septations that are non-enhancing on MRI. So very typical for fibroadenoma. This is an example for intramammary lymph node. Again, as I mentioned, a bright, strong T2 signal is suggestive of benign lesion. And this is the T2 image in the middle. And you can see that this is homogeneously bright. This is the mass that is enhancing within the breast. And this is the non-fat set, T1 pre-contrast. And I know it's hard to see, but if you'll trust me, there is a bit of a bright dot in the center. This is the preserved fatty hilum and the blood vessel that feeds it. So this is a very typical intramammary lymph node, normal finding, no need even to mention it. Just take a look, make sure you agree, you're certain that this is a lymph node and not a developing mass. So benign imaging characteristics, overall morphology needs to be smooth, margins, and well-defined, corresponding high T2 signal. Lesion contain macroscopic fat is also suggestive of a benign lesion, which is why, again, we included the non-fat set images. Lesions containing macroscopic fat or a high signal on, which is high signal on T1, of course, you know that. A type 1 persistent enhancement kinetics. Degree of enhancement is similar to BPH, can be more or less, but again, some lesions like the fibroadenoma can increase a bit more. And fibroadenomas have that typical non-enhancing septations. Again, not always. Some examples for malignancies. So this is a 27-year-old, a high-risk patient, again, presented for screening, just like the first case. And just like the first case, there is, when we look at the MIP sequence, we can immediately see that there isn't much background parenchymal enhancement. There is non-mass enhancement within the left breast outer aspect, just like in the first place. Here, maybe more architectural distortion, though. On the sagittal, you can see the extent. You can see a bit more of the architectural distortion. On the T2, this is the T2 images, you can see that parts of it are very strong, bright signal on T2, but some areas within it are not. So this is not homogeneously bright a T2 signal. This is more heterogeneous and not as suggestive for benign findings. This is the post-contrast subtraction images. And you can see that the enhancement is pretty strong, definitely stronger than the background parenchymal enhancement. And it's not homogeneous, it's heterogeneous. Some areas do not enhance, this does not enhance within that non-mass enhancement. So again, this looks very concerning, very similar to the first case, but this is newly developed. It wasn't there on the previous, like it was in the prior. So this was definitely biopsy-proven malignancy. So the clinical scenario and whether something is new or not, and all the images features together and morphology, everything needs to be accounted together. This is a 36-year-old with recent biopsy-proven right breast malignancy. And she was referred to MRI for assessment of disease extent. So this is her MRI. Again, we can start with the MIP. This is the same patient that I showed you the fibroadenoma. So that was the fibroadenoma that you've seen before. It's the same patient. The reason we saw the fibroadenoma, it was an incidental because she had cancer on the other side. And on the MIP, you can already see this irregular, heterogeneously enhancing large mass within the right breast. This is the T2. You can see that there is some more subtle non-mass enhancement extending anteriorly. With the mass itself has high signal on T2. We said it's suggestive of benign, right? But when you consider the morphology of that lesion, the margins that are irregular, speculated, and some extension anteriorly with not so bright T2. So we might consider this is probably maybe necrotic changes, which are also bright on T2 because it's basically fluid. But again, we need to consider everything. There is also some changes in the skin here. The skin looks a bit thicker when we compare to the other side and brighter. So maybe more adenomatous changes within the skin. This is the T1 non-fat set. We can see that there is clearly no fat within that lesion, and something is still going on anteriorly. This is the pre-contrast one. So we already see there is a different signal between the surrounding, the periphery of the lesion and the central of the lesion. On the post-contrast, the non-subtracted and subtracted, we can clearly see that there is irregular rim enhancing mass. Again, I'm using the BI-RADS lexicon for description, with thick, irregular margins, and the central is not enhancing. So this is very concerning for a malignancy. There is even a satellite lesions just anterior to it. And some skin changes, as we're seeing mostly on the T2 because of the adenomatous changes. So this is very important. And of course, we need to see whether this involves the chest wall, the nipple, if there are lymph nodes along the intramammary chain, if we see lymph nodes in the axilla, and anything else that might be involved. This is the same patient, same mass on the sagittal view. Again, irregular, thick rim enhancing mass with central necrosis and no enhancement. This is the correlate on ultrasound, irregular, hypoechoic, lobulated and angulated margins mass. And this is the correlate on mammography. We can see the mass, we can see some tissue distortions and even calcifications. Again, in all those calcifications, we do not see on the MRI. We do see some enhancement extending anteriorly, but now looking at the mammography, we understand why, because we see some calcifications. So it could be DCIS extending beyond the main mass. Next case, similar case, again, diagnosis of malignancy for disease extent. So again, This is her mass. She came with a palpable. It was biopsy. It was proven malignancy. We saw multiple other masses on ultrasound, and she had a very dense breast, so she was offered MRI to assess for disease extent. And already on the MIP, you can see how many masses within the left breast. In addition, she has increased, moderate, I would call it, background parenchymal enhancement with multiple foci or small masses, as the current BI-RADS requires us to call it, bilaterally. So it's very hard for us to say for sure that none of these are another focus of disease. So this is something we need to mention in our report, that we are limited due to the increased marked background parenchymal enhancement. In addition, note the abnormal lymph nodes in the axillary region, which we don't see on the contralateral side. This is the same patient, different slice level height. With, again, I showed the same lesion at the beginning, if you remember this. So this is time 1, time 2, type 3. You can see the background parenchymal enhancement increases. And you can see that the lesion is becoming less and less bright along the timeline, which is in keeping with type 3 enhancement kinetics, another concerning feature. Same patient, different level. Again, the different timeline. You can see that this is a bit more brighter, all those lesions, than here and then here. So this is again demonstrating washout. And this is the T2 sequence. See how we can barely see those lesions on the T2. It's not, definitely not high T2 signal, not bright T2 like we expect with benign lesions, or like with the necrotic lesion that we've seen in the last case. So this is iso-intense or intermediate signal intensity on the T2, another concerning feature for malignancy. Same patient, sagittal, in different slices, again, multiple masses. We need to mention that there is a fair distance between the chest wall, so no chest wall involvement, no skin involvement, no nipple involvement. There is a fair distance between the nipple. And this is just a mammography correlate. See how dense breast, how much can hide within a dense breast. So this is the importance of MRI, and where MRI can elevate and make us be much more accurate and tailor the surgery and the treatment for that specific patient. Because here we can basically see nothing. Another case, sorry, 40-year-old with malignancy, again, a mass within the left breast. We can see that there is skin changes compared to the other side. If you're unsure, always compare to the other side. We can see the same on the MIP. But this patient is for neoadjuvant. So I brought here the before neoadjuvant and after completion of neoadjuvant, and look at the difference. So if we start with looking at the MIP from February to 2024 and June 2024, we can see that there is nothing left there. The mass is completely resolved. Also on the subtracted images, nothing is enhancing there, while look at the mass that she presented for it. So this is the importance of neoadjuvant. And this will help the surgeon make the surgery smaller, potentially, unless you want some mastectomy, of course, and less aggressive. This is another example of encapsulated papillary lesion with good response to a neoadjuvant treatment. So the patient presented with a palpable lump. Look at that big mass within the left breast, very thick, irregular, solid component demonstrating enhancement. This is the MIP image. And this is the MIP image on the post-neoadjuvant. Nothing is barely left there. This is the subtracted images. So there is some residual rim enhancing with cystic changes, but look at the size and the difference in this one. So at this point, we can localize only this lesion for the surgeon, again, to have a much smaller surgery with negative margins. So that's another example of a good near complete response, unlike the previous case, which was complete response. So when staging for malignancy, Try and look for chest wall involvement, nipple involvement, skin involvement or changes, satellite lesions and lymph nodes in level 1, level 2, level 3, or intramammary chain, and metastatic. So always include the ribs, see if you can see incidental lesions and metastatic rib lesions in the liver and everything else that mediastinal lymph nodes perhaps, depending what you have included in the field of view. This is an example of a lesion with the chest wall involvement. So you can clearly see there is no separation, even a bit of invasion with the chest wall. This is a different case where there is clearly separation with the chest wall. So we can say for sure that there is no chest wall involvement. This is a non-mass enhancement. It's abutting the chest wall, so we cannot exclude direct invasion, but we also don't necessarily see one. But we can say that there is no involvement of the nipple here. This is another case of clear inflammatory changes within the breast with skin adenomatous changes. This is a T2 sequence. The skin is thickened with a subcutaneous edema, which we don't see on the contralateral side. So all of these factors makes a difference for the patient, for the surgeon, for the oncologist to tailor the proper treatment for that patient. How am I doing with time?
I think we have about 15 minutes more. I don't know if you want to just go ahead with finishing off the lecture, and then maybe we can do a few questions from the quiz.
Okay, so I can either jump to the quiz and skip implants.
How long? Yeah, if you have a few minutes, maybe you can just finish off implants. I'm sure everyone will appreciate it because we can see everyone's really enjoying it. Everyone's requesting for your slides already.
Okay, so I'll try and do it quickly. So just a few words about breast implants. There are two main types: the silicone and saline implants. Most commonly, the silicone is used, and there are two main types of surgeries. If the implant is placed prepectoral or retropectoral, sorry. And as a reminder, I did mention briefly in the beginning, but when the clinical question is not the breast parenchyma, we do not need to inject. We need to tailor the study and the protocol specifically for breast implants. So we need to include silicone sensitive, so silicone hyperintense, water hypointense, and silicone saturated, meaning that the silicone is hypointense and water is hyperintense, just so we can differentiate between capsular seroma, post-surgical seroma, if there is fluid around the implant, kind of an inflammatory changes between that and actual silicone or saline being outside of the implant itself, to differentiate between that and a true rupture. So it's a different protocol study. So implant ruptures, we have two main types. It can be intracapsular or extracapsular based on the location. Just like with most surgeries, after we put the implant inside the breast, the body forms like a dense fibrous tissue around it to try and protect. It's kind of a scar tissue around the implant. This is basically the capsule. This is what we call the intracapsular or extracapsular. It does not refer to the capsule of the implant itself. It's the capsule that is formed by the body. And that's an important thing to remember. So intracapsular rupture means that the implant material is outside of the implant, but within the body-formed capsule, the fibrous tissue capsule. Extracapsular rupture means that the capsule, the silicone material is outside of the capsule that was formed by the body, by that scar tissue. And once it gets outside of the scar tissue, it can be absorbed by the lymph nodes, which is what on ultrasound we typically see the snowstorm lymph nodes. There is a typical appearance, or you see a silicone signal uptake in the lymph nodes, and that's suggestive of an extracapsular leakage. So just a few examples. There are some signs that are described in radiology to describe intracapsular: the Linguini sign, the keyhole sign, and the teardrop sign. This is the Linguini sign, just like Linguini, I guess. And this is suggestive of intracapsular rupture. This is the capsule. The dark thing that you see around the capsule, it's the capsule that is formed by the body. This is an example of extracapsular injection. And the reason we know that, because if this is the silicone implant and this thick, dark surrounding is the capsule, we see silicone signal outside of that capsule. So this is extracapsular rupture. But don't mistake that with radial folds. Radial folds, it's normal appearance of implant. Just when it's fold, it's kind of like, sorry, it's not an implant, but it's a game for my kids. Just kind of a fold of that implant, and it can be normal, but usually it connects with the surroundings. So it should not, it looks very different from the linguini sign. So just try to be aware of that and not confuse the two, because that's a common mistake I see with many residents and fellows. Shortly about MRI biopsy, I'm not going to go into too much details, but technically the idea is anything that is not seen on other modalities and needs occult on mammography or ultrasound, we can do MRI biopsy, which is why it's important for facility that is offering breast MRI to do the breast biopsy in case needed. Of course, we need to mention complications like with any other invasive procedures. And technically, according to BI-RADS, anything that was biopsied with MRI and was benign proven, we need to recommend BI-RADS 3 with 6 months follow-up. For that, if it was malignant, of course, it's easier. Then you just refer to surgery or do the next step depending on what you got. This is how it looks like. It's just an illustration. There is a dedicated grid. The breast is compressed, unlike with the routine MRI where the breast is simply falling through freely through the breast coil. Here it's compressed. We inject, we target. There is a special system and a computer system for that. With a dedicated equipment, and of course you need everything MRI oh my God, MRI approved and there's dedicated equipment for that. This is an example. This is the breast. Usually one breast is imaged, but we can do bilateral MRI. It depends on the machine. The resolution is a bit less, but still it's doable. So this is the lesion that we targeted. This is the compression with those squares that you've seen in the previous slide. Once we see that, we inject. We see that this is enhancing, we target it, we'll calculate the everything. It's kind of similar to stereotactic guided biopsy. The machine calculates the location, we insert the needle, and we take the sample, we harvest, it's a vacuum needle, so it's a big sample, and this is the post-biopsy cavity and the clip. And of course, we do that when we have the previous MRI in front of our eyes. This is the previous MRI, the bilateral, with the lesion, both on axial and sagittal. Again, it helps us understand where we are, and then we know how to position the patient for the biopsy based on where we expect the lesion to be. Quick summary, MRI plays an important role in breast imaging, both for screening and diagnostic setting, the most sensitive study in breast imaging that we can offer. But keep in mind, with sensitivity, false positive increases as well. So it's a complementary study, not replacing anything, but it's in addition to mammography. It's a good technique, and imaging quality are crucial for proper diagnosis. So motion artifacts and all of that, we need to be extra careful, because every tiny thing, we don't want to lead to unnecessarily workups and false positive biopsies, false negative or false positive unnecessary biopsies, basically. Follow-up BI-RADS for MRI to organize your report structure, description of findings, providing final impression and recommendations. And again, try to remember to avoid BI-RADS 0 with MRI unless you really have to. So that's it for my talk. We can proceed to questions. I have prepared 20. Do you want to use your platform?
Well, I've loaded it onto the poll, so I can't put it up.
To stop sharing?
No, you can continue to share.
So will I be seeing the questions or how does
Yeah,
that work?
you should see them. I'm just trying to pull them up right now, so everyone should see them.
Oh,
Okay,
yeah.
yeah, everyone can go ahead and answer the first question, maybe. So we've got
There is a close tie
yeah.
between the first and second question. So the question is, what is reported sensitivity range for breast MRI? So I did mention that in the beginning. For sensitivity, it's between 85 to 100%. Specificity is a bit less, between 70 and 90. And the sensitivity is even higher for a high-risk patients. So the correct answer is B, 85 to...
Well done. Well done
What?
to those who got it right.
Yes.
All right, so we'll move on to the second question. Looks like we've got some speedy answers here.
Yeah.
So the second question was, the following sentence is incorrect regarding MRI technique. And the most amount of people that answered the question were about 60% of them answered women are lying are scanned lying in a supine position.
Very good. That is correct because the patient lie face down, right, with the breast hanging out the breast coil. So yes, very good.
Okay,
Next,
guys, please go ahead and answer number 3 for us.
I'll read the question in the meantime. The basic principle behind contrast enhancement is neoangiogenesis, which leads to the formation of leaky vessels and and allows for faster extravasation of contrast agent. So true or false? Anyone? It's only 50-50.
I think everyone's asking me to put the poll up again. Nope. Okay. All right, so we've got 50-50 here as well.
Yeah, so the correct answer is true. That is the basic principle. It's extravasation of the contrast into the tissue because of the abnormal neoangiogenesis and the vascularity within the lesion. So yes, it is true. Next question, number 4.
I think everyone can't see the poll. I'm just going to put it up again.
You need to scroll down. That's what I figured.
Go, guys. Can you see? Please start answering from number 4.
On standard breast MRI protocol, images are obtained. So 60 to 90 seconds after contrast injection, immediately after, at least 3 minutes after injection, or timing is not that important. So the question is about standard, right? The standard, the classic, not the ultra fast and not the abbreviation. And this is yes. So the correct answer is A, is first. 60 to 90% is 60 to 90 seconds after injection.
Okay, great. Let's move on to the next question.
5th question. The standard breast acquisition protocol should include the following sequences. So T2 weighted bright fluid sequence, pre-contrast T1 weighted sequence, multi-phase post-contrast injection T1 weighted sequence, or all of the above. So if you remember, we need the T2 to see if the lesion is bright T2, which is more suggestive of benign finding. If it's not as bright, T2 is more concerning. Pre-contrast is important to see whether finding is truly enhancing. And you need the pre-contrast for the subtraction, right? The subtraction is kind of the post minus the pre. So you need that. Multi-phase contrast injection T1, that's the different times we take the image after injection. So yes, I see 2 answered all of the above, and that is the correct answer. Okay, thank you. Question number 6. Which is correct regarding enhancement kinetics? So malignancies enhance both earlier and faster than benign lesions. benign lesions enhance earlier and faster than malignant lesions, or most cancers start to enhance 2 minutes after IV injection, or malignant lesions usually do not enhance. So which one is the most?
Shame. I think people have been pressing submit, guys. Don't click submit, just answer. Don't submit your answer because the poll will disappear if you do that. So I'm just going to restart it for everyone whose polls have disappeared. I think we were on question number 6, right?
6.
Yeah.
So which is correct regarding enhancement kinetics? So the malignancies enhance both earlier and faster than benign lesions.
We've got some answers in the chat for C.
I don't see any answers.
In the chat, someone's posted C. So most cancers start to enhance 2 minutes after IV contrast. So one person's answered that. And then we've got an answer for A as well.
Yeah, so A is more accurate. Most cancer starts 1 minute to 90 seconds. That's the peak of the enhancement. And some studies show that cancers enhance even in the first 10 seconds. So it's faster than that. So the first answer A is the correct one. Question 7. Which enhancement kinetics is most suggestive for malignancy? Type 1, type 2, type 3, all enhancement type are equally suggestive. So type 1 is the persistent, type 2 is the plateau, type 3 is the washout, and type 3 is the correct answer. So very good to the one who answered. Question number 8. Which of the following, sorry?
Yeah, there are more people in the chat agreeing with that answer. So I think they have been listening to you talk. All right.
Which of the following is not an indication for breast MRI? So screening of high-risk patients, staging and restaging following neoadjuvant, evaluation of findings or clinical concerns, or screening for all patients depending on MRI availability. Correct. So the question is about is not, which one is not. So we cannot offer MRI for everybody, like mammography. It's only for specific indications.
Well done to everyone in the chat who's also answered that question. D was the correct answer.
Which of the following is incorrect regarding high-risk patients? So those patients have more than 20% lifetime risk for breast cancers, positive genetics for such as BRCA 1 or 2, strong family history and dense breast, or all females are at high risk breast cancers, more than 20%. So this is similar to previous question. And which one is incorrect? Anything in the chat?
It's like everyone's a bit shy to answer this question.
There is no judgment. I don't even see your faces. The correct answer is D. The incorrect answer is D. So not all patients or female patients are high risk. Only those with genetics, family history, or and dense breast, or specific reason to have a high risk, more than 20%. So BI-RADS for MRI, choose the correct statement. Oh, ignore the background. B1 should be applied when no findings are detected or described. B2 should be applied when benign findings are described. B3 should be applied for probably benign findings where follow-up is needed. B0 should be avoided when reporting MRI, or all of the above. So I made these questions not to trick you, but more kind of to summarize the main points I want you to take away from the talk. And here all of the above are correct.
So some people have answered, 3 people have answered all of the above.
Okay, so very good to you three people. Next question. Tell me when to stop, depending on your timeline.
Yeah, maybe we can, does anyone have any pressing questions they'd like to ask Dr. Grisaru for now? I just want to know so we can see how we can do with time. Do you have somewhere to run to, Maya?
No, I made myself free, so I'm good.
Yes, so we do have a question if we want to just
Sure.
raise it quickly. So it's Ugu. I'm going to enable you to talk now so you can ask Dr. Maya your question.
Hello, can you hear me?
Yes.
Hi, yes. I did ask a question about POTS. So obviously this is not like an implant session. I do appreciate that, but could you just throw some light on implants? Recently we had a patient who we had to scan. She had like the RFID POTS. It was conditional and we had to scan her, but our policy does not allow us to scan the other ports. So my question is, knowing that this is really a huge risk for patients coming for breast imaging, why then do they have to go have these type of ports that are not allowed in MR?
Sorry, what do you mean by POTS?
They do have ports where they you know the radio frequency ID ports?
POTS.
Yes, radio frequency identification ports. Some tissue expanders, they have RFID ports that are MRI conditional.
You're talking about the tissue expanders?
Yes, some breast tissue expanders.
Yes, there is a magnet there in the implant.
So some of them have magnetic ports and some don't have. So my question is, you know, why do we then have to, I mean, why do we have that technology knowing that these patients definitely would have MRI at some point? Is it something that gets removed after some time?
Yes, so the use of tissue expanders, it's temporary implant. They are not considered as a permanent implant. And I know all implants are technically temporary, right? You have 10, 20 years limit for an implant, technically. But the temporary one, it's only to expand the area behind the pectoralis muscle. And then eventually within 6 months, 1 year, 2 years maybe, the patient needs to have that replaced with a permanent implant, either saline or silicone, but it's not supposed to stay there because just it has a big magnet, so the surgeon can put a magnet from the outside and can inject saline into the implant and expand it slowly over time. This is how they create that cavity for the final implant. And that's why the magnet is here. And it causes huge artifacts on MRI, and it's not compatible with MRI. You can do the MRI, but you will just see a dark hole and you will not see anything. So it's pointless. But it shouldn't stay there. Like those patients should have that implant replaced.
Thank you.
Thank you so much for your question. We have one more question, if that's okay. So it's Mobolaji. I've enabled you to talk, so you can go ahead.
Okay. Thank you very much, Dr. Maya. My question is based on giving BI-RADS 0, would we recommend on contrast enhanced, because that requires further imaging? Would we recommend contrast enhanced mammography? But it's like taking a step back because MRI is supposed to be the gold standard for making diagnosis. So I find it very challenging to give a 0 on MR.
Sorry, you're asking, I heard you a bit interrupted, but you're asking if to recommend contrast mammography after MRI?
Yes, yes.
So the answer is no. There is no need to do two contrast studies, basically, right? Because both of them are contrast studies, and you want to see if something enhances. So there is no point in offering both. Unless you started with contrast mammography and this is insufficient or there is marked background parenchymal enhancement, and you think you can gain more information with MRI, with your ability to scroll through and to see the T2 correspondent and how it behaves on the different sequences, then you might consider that. But in general, there is no reason to inject twice and to do two contrast studies. Definitely not when contrast mammography comes after the MRI, because on MRI you get so much more information. And even if the MRI is limited and you have extreme background parenchymal enhancement, you will see the same on contrast. Only on contrast, you cannot scroll through and differentiate between the findings or see how it behaves on other sequences. So it's really, there is no reason to do that.
Okay, sorry. So my question, that's another one. So if we have an inconclusive MR where we have a BI-RADS 0, what further imaging could we recommend?
It depends what you want to do with it. It really depends on the clinical scenario. If there is a mass, for example, I'm trying to think of a recent case that I had. For example, a case of staging a patient, and you have a lesion, or for example, that case that I showed with a cancer on one side and incidental fibroadenoma on the other side. So in that case, I see the fibroadenoma on the left side. If you remember, the lesion was, the cancer was on the right, and there was the mass on the left. It looks like fibroadenoma, very typical. All the imaging features support fibroadenoma, but I cannot, I want to confirm that with ultrasound. And I don't want to give it BI-RADS 3 because I don't necessarily want to now stop with the cancer assessment and go to BI-RADS 3. And I also don't want to biopsy that fibroadenoma because it does, if it's confirmed fibroadenoma on ultrasound and I have all the imaging characteristics on MRI, so there is no reason to go there. That's an example on where I would use the BI-RADS 0 with MRI, but I will be clear in my report and mention likely fibroadenoma in the contralateral breast, confirmation with ultrasound, with second look ultrasound is recommended. Assuming no concerning features on ultrasound, the patient can proceed to surgical referral or oncological referral or anything like that, and then give it a BI-RADS 0. And then the person doing the ultrasound, assuming they confirm that this is a fibroadenoma, nothing concerning, they can give the BI-RADS 6 because now it's completed and the patient can be sent to the surgical department. Does that make sense?
Yes, it does. Thank you very much.
I think everyone seems like they're keen to finish off the quiz, but before that, maybe we can take one more question.
Sure.
Okay, so Dr. Odafe, I'm going to enable you to talk.
Hello, good evening. Hello.
Hello, yes, we can hear you.
Good evening. All right, thank you for the interesting lecture. I asked if what the BI-RADS category would be if you find a patient who has clinical features suggestive of a Paget's disease of the breast, as cracking and flaking of the nipple, and then on MRI, the only thing we saw was a slight thickening of that nipple areolar complex with a differential enhancement. But the breast parenchyma itself looks normal. There's no increased background parenchyma enhancement. No. In such situation, what BI-RADS do we give and what do we do as a follow-up, as a recommendation for the patients?
So you're asking if the nipple is, basically there is some clinical concern, but you couldn't see anything concerning on MRI.
Yes.
Correct. So you give the BI-RADS based on what you see. I mean, you give a BI-RADS 1 or 2, depending on, if you just see a normal areola within normal limits, you can describe it and give it a BI-RADS 1 or BI-RADS 2, depending on your description. But you give the BI-RADS based on what you see. And then you can refer for further clinical assessment or clinical follow-up or surgical consultation. Because I don't know if this is something cosmetic that bothers the patient or something occult. Maybe she needs a punch biopsy, but that's not our territory, right? We are, as radiologists, we are usually in most places not the ones doing the punch biopsies, the skin biopsies, but you give your BI-RADS based on your imaging findings. So if you, same as if you would read the mammography and it's negative, even if you know the patient has cancer, but that I mean, or not, that's not true, that's not accurate, but if you know the patient has a fibroadenoma on ultrasound, but you're reporting the mammography and you do not see that that fibroadenoma on mammography, you will still give it a 1 or 2.
All right.
depending on what you're describing.
All right. Thank you. Well understood.
You're welcome.
Okay, so I think we're back to the quiz then. So we're on question 11, Dr. Maya.
Just a minute. Question 11. Okay, so which of the following is incorrect regarding BI-RADS? So BI-RADS 3, chances of malignancy between 2 and 5%. BI-RADS 4, chances of malignancy between 2 and 95%. BI-RADS 5, above 95%. BI-RADS 3, between 0 and 2 chances of malignancy. So which is the percentage for BI-RADS 3, if you remember? So
we have two answers. One person has answered A and the other person has answered D.
I'm looking for the incorrect. Incorrect is the first one. So BI-RADS 3 is between 0 and 2, like in the last here. This is the correct one, and not 2 to 5. BI-RADS 4 is between 2 to 95, just like the BI-RADS A, B, and C. And the third answer is correct as well. So the incorrect answer is the first one. 12. The following statements are correct regarding BI-RADS 3. So reserved for specific findings that are very likely benign. Following up intervals at time 0, 6 months, 12 months, and 24. Follow-up intervals should be as long as needed. We're looking for the correct statement or answers A and B. So the correct answer is A and B. It should be reserved for specific, probably benign findings. And the follow-up is at 2, 6, 12, and 24 months, and not as long as needed. We don't usually offer follow-up for 5 years, 10 years. We have a limit, and that's 2 years. After we prove stability for 2 years, you can downgrade it to BI-RADS 2 and call it a day. Question number 13. So biopsy should not be recommended for newly developing mass. Yes, definitely should be recommended for that. Lesions with irregular and ungulated margins. Obviously, it should be. Stable lesions, correct. No reason to biopsy stable lesions. Enlarging mass, definitely offer a biopsy. So yes, you are correct. Question 14. Which of the following statement regarding MRI findings is incorrect? Malignancies may demonstrate benign appearing MRI features. And we are looking for the incorrect. So malignancies, if you remember, they can demonstrate benign imaging features. We even said that 9% of them will show benign type 1 enhancement kinetics. Mass assessment is based on morphology and enhancement kinetics. Yes, this is the whole point of MRI and the additional information we get in addition to mammography and ultrasound. Benign lesions will never demonstrate washout. Well, I learned in med school that never say never and never say always in medicine. So that's already there. In a scenario in which the stability of the finding is unknown, periodic surveillance is appropriate. So that is also correct. If you remember, if we don't know if something is new or was there, for example, if we have a baseline study, then either confirmation with second look ultrasound that no concerning features are found, and follow-up is usually the appropriate way to go. So the incorrect benign lesion will never demonstrate washout. That's the incorrect. If you remember, lymph nodes are benign and to demonstrate washout. Question 15. Second look ultrasound should be offered in the following cases. Any lesion seen on MRI. That will be, we will never end if we'll offer second look ultrasound for every lesion we see on MRI. Lesions with intermediate or suspicious features, biopsy B4 or 5. Lesions larger than 5 millimeters, which are more likely to be seen on ultrasound. or questions B and answers B and C. So yes, the correct answer is B and C, lesions that are concerning for the possibility that maybe we will be able to biopsy them under ultrasound instead of MRI. And technically I would go for lesions that are larger than 5 millimeters because there is more chances that we will be able to see them on ultrasound. Lesions smaller than that, I don't know if I would even try. I would probably just go ahead with the biopsy under MRI. Question 16. So typically benign lesions MRI imaging characteristics include smooth, well-defined margins. Yes. Homogeneous, strong high T2 signal. Yes. No enhancement or homogeneous type 1 enhancement. Correct. May contain microscopic fat. So yes, 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 and yes. So all of the above. Good job for the one who chose that. Question 17, which of the following is incorrect regarding typical malignant imaging features? So is incorrect again. So irregular, spiculated, and microlobulated margins, that is typical. Heterogeneous enhancing mass, that is typical for malignancy. Stability over 2 years, that's usually not typical. That's our way to determine that something is benign, in fact. So that's already the answer, and can demonstrate all 3 types of enhancement kinetics. So that's also true. So the correct answer here is C, the third one. Question 18. When staging for breast malignancies with MRI, what do we need to look for? So chest wall involvement, nipple involvement, satellite lesions, lymphadenopathy in all 3 levels, and all of the above. So naturally, the question is all of the above. So good job here. 19. Which of the following is suggestive of extracapsular implant rupture? So radial fold, if you remember, this is a normal variant, just a fold in the implant. Silicon signal in lymph nodes, definitely. It means that there is uptake of silicon in the lymph nodes, which is extracapsular. Linguini sign is a sign for intracapsular rupture, so not extracapsular, so that's incorrect. Keyhole sign, another sign for intracapsular rupture. So all the signs are usually for the intracapsular, and only seeing actually extracapsular silicon is the indication for extracapsular rupture. And final question, MRI-guided biopsy should be recommended in all scenarios except. So I know I was brief on that section. When a suspicious lesion is only seen on MRI, when no definitive sonographic correlate is found on a second ultrasound, for all lesions, if MRI, sorry, it keeps jumping, if MRI is available, or for lesions that are occult on other modalities. So as the question is except what is incorrect, so yes, the 5 here who answered this, very good. Of course, we cannot offer MRI-guided biopsy for every lesion that we see.
Okay, thank you for everyone who answered the poll. I know there were a few technical difficulties, but thanks for participating with us. Thank you to everyone for joining. I know we've run quite over time. This is quite a lengthy but enjoyable seminar. So thanks so much for Maya for spending 2 hours with us and sharing all of your expertise. We all really appreciate it. Yeah, I think that we can end the seminar for today.
Thank you so much, everyone. You've been great, and thank you for having me. Really, it was a pleasure. So have a good day or night.
Good night for everyone.
Night. Yes.
All right. Take care.
Bye.
Bye.